Hello, I'm just going to check that everyone can see me and hear me because I can't see myself.
Yeah, we can hear you.
Great, okay. So it's 1 o'clock, so I'm going to be prompt to start because I know everybody's quite busy. My name's Ros Mudenha. I'm one of the consultants in 9 Wells. I'm an obstetrician and gynecologist. And today, the topic, I am actually honored to be talking about Black lives in the sense that my focus is going to be from an obstetric and gynecological point of view. It's been quite a hectic year with the Black Lives Matter movement, but what I want to concentrate on is how Black lives are affected in obstetrics and gynecology. So the UK Quality Act in 2010 said that the public sector organizations have a duty to collect equality data and to prevent evidence and to provide evidence against agreed equality outcomes. And there is legislation that requires all NHS boards to collect and to use equality data about their service users. The Scottish Government has also published the Equality Monitoring Guidance, which was published in 2012. When it comes to ethnicity, it's important to know that ethnicity is not a fixed characteristic, and nor is it essentially necessarily consistently defined. It relates to quite a variety of factors, including nationality, culture, heritage, and skin color. People's perception of their own ethnicity may also be influenced by a range of social and political circumstances, which may change in different contexts and over time. And what they've noticed is that sometimes there is actually a discrepancy between one's ethnicity that they say when they're alive and what is actually put on a death certificate when they're not able to define their own ethnicity. In Scotland, the census in 2011 said people who described themselves as African, Caribbean, or Black made up only 1% of the population of Scotland. The biggest concentration of other ethnicities that are not white Scottish or white British are in Glasgow, which has 12%, where they make up 12% of the population, followed by Edinburgh and Aberdeen, where they make up 8%, and then Dundee City, where we are based, has 6% of ethnic minorities. So if you look at the Scottish data on the census, actually it's quite difficult to know who is Black, because if someone describes themselves as African or African Scottish or African British, it doesn't tell you about their ethnicity. Some people might describe themselves as other African, Caribbean, Caribbean Scottish, Caribbean British, Black Scottish, Black British, other Caribbean or Black. So it's very difficult to actually know who is Black, who is other. I'm going to share a story about a woman called Nicole Thea. She was a 24-year-old who was a dancer. She was a YouTuber with over 168,000 subscribers. She was a social media influencer. She had over 240 Instagram followers, and she lived with her partner, and she was expecting a baby boy called Drain. On July the 1st, Nicole released a video called The Worst Thing About My Pregnancy. And in her own words, she said, "Yeah, the worst thing about my pregnancy is that I'm always out of breath. I could walk from here to the end of the room and I could feel like I'm dying. I went to my midwife and I said, oh my God, is this normal? I don't understand." She was like, "Yeah, you're carrying a child. There's a whole human inside of you. Your baby is eating." Nicole then said, "I feel the baby is eating me. That's the worst thing. It's so hard." On the 12th of July, there was an Instagram post from her partner which said that unfortunately Nicole had died. This was very shocking to the Black YouTube community, and it also made mainstream media, including the BBC. Nicole apparently had suffered from severe chest pain, backache, shortness of breath. She was 8 months pregnant, and she and her baby son died. In the United Kingdom, we have an ongoing audit, which looks at the outcomes for Black and for women in general in maternity. It's called Embrace, or Mothers and Babies, Reducing Risks Through Audits and Confidential Inquiries across the UK. This has replaced the confidential inquiries into maternal death, which we used to have preceding this. Because we're looking at Black women, I have changed the emblem that is on Embrace, because race is what we're talking about, particularly Black women. And instead of the flowy hair, I have put an afro on the emblem. So Embrace released some statistics about COVID-19 deaths in the 2 months in this year related to COVID-19 from March to the end of May. 10 women died. 9 of the women died up to 6 weeks after their pregnancy. 1 died between 6 weeks and a year after the end of the pregnancy. 8 women died who died from COVID-19 were all in their 3rd trimester at the time of the disease onset. And all women who had confirmed SARS-CoV-2 infection died after giving birth, and 2 of their babies were stillborn. All of the 10 women who died, 7 or 88% were from Black and ethnic minority groups. We now know that evidence suggests that individuals of BAME background are at a high risk of developing severe complications of COVID-19, and this also applies to pregnant women. In the UK, BAME pregnant women generally have worse outcomes in pregnancy and birth, and this was also published by UCOS. Black women are 8 times more likely to be admitted to hospital with COVID-19, while Asian women are 4 times as likely. Women from ethnic minority backgrounds have long been known to face additional maternity risks, with maternal mortality rates being significantly higher than for white women. We know that 55% of the pregnant women admitted to hospital with COVID-19 are from a Black and ethnic minority background, even though these women only make up a quarter of the births in England and Wales. Women of BAME background or with other risk factors such as hypertension, diabetes, or raised BMI should actually be advised that they may be at a higher risk of complications of COVID-19. They should seek advice without delay if they're concerned about their health. And this is published from the RCOG Coronavirus Pregnancy Guideline from 2020, which has been updated in October. So what are the reasons why Black women and women of ethnic minorities have poorer outcomes from COVID-19? It's very unclear. Some people have postulated that it could be socioeconomic, there could be genetic factors, there could be differences in response to infection, or it could be to do with vitamin D deficiency, but further research is required. So recommendations are that women of BAME background are encouraged to seek advice, as I said, without delay, but as healthcare providers, we should be aware of the increased risk and have a lower threshold to review, admit, and consider NDT escalation of symptoms in women of BAME background. When reorganizing services, maternity units should be particularly cognizant of evidence that BAME individuals are at a particular risk of developing severe and life-threatening COVID-19 disease. So we're going to talk a little bit about vitamin D deficiency. Studies have shown that 94% of South Asian populations in the UK are diagnosed with vitamin D deficiency in winter. And people of BAME background with melanin pigmented skin are at an increased risk of developing vitamin D deficiency. So it goes without saying that women with a darker skin, or those who cover their skin when outside, may be at a particular risk of vitamin D deficiency and insufficiency, and they should be recommended to take supplements of vitamin D all year round. In the UK, we would prescribe vitamin D to women who are of ethnic minorities with a higher BMI, and they're encouraged to take supplements, but we need to question whether the supplements we're giving are enough for women with darker skin. If you look at this slide, it tells you that Black and Asian women have a higher risk of dying in pregnancy. The risk for a white woman dying because of pregnancy-related illnesses are 8 per 100,000. For 8 Asian women, it's twice that. And for Black women, sadly, it's 5 times the risk at 40 per 100,000. In the Embrace report of 2018, they reported that we need to have continued awareness of these inequalities within our own services. And we need to question whether the way we deliver care before, during, and after pregnancy unconsciously disadvantages different women, whether on the basis of their ethnicity. So the anaesthetists have also updated their guidelines to be aimed at recognizing the complications that Black and ethnic minorities face. And also the Action on Preeclampsia, APEC, has said that Black women compared to white women are 3 times more likely to develop preeclampsia in their pregnancies. When we look at women who die in terms of country of birth, a woman who is born in Nigeria is 6 times more likely to die in pregnancy than a woman born within the United Kingdom. So what are the causes of maternal deaths? So if you look at this slide, it's a busy slide, but the main thing to take from this is that we have direct causes and we have indirect causes. As an obstetrician, we deal with a very small piece of the pie in terms of causes of maternal deaths, and this is where we would have interventions. But I know that if you look at the bigger pie chart, it actually means that we need all specialties to be on board. We need neurologists, we need cardiologists, respiratory, GPs, everyone to understand that the largest cause of maternal death is not confined within the specialty of obstetrics and gynecology, and that actually we all need to be aware of the causes and to work together to, if we're going to make any headway in reducing maternal deaths. So of women who died from cardiac causes, 12% were of Black African origin. This is a case of a young woman who had a postpartum hemorrhage of a liter, reattended A&E because she was having symptoms of palpitations, orthopnea, and dizziness. These were attributed to her being anemic, so she was transfused and sent home, but she contacted the hospital again because she was feeling breathless, but was advised to remain home, and she sadly collapsed and died shortly afterwards. And her post-mortem review revealed that she actually had rheumatic mitral valve disease. Of women who died from hypertensive disorders of pregnancy, 33% were of Black or other minority ethnic group. When it comes to early pregnancy complications, there were a total of 6 in that group, and 50% were actually of Black or other ethnic minority group. So MDT team working is very important. When a pregnant woman or postpartum woman develops a critical illness, there is no single specialist that has all the skill and knowledge that a woman will need if she's to recover. So we need effective MDT working, which is as a prerequisite for high quality maternal critical care. We know that NICE, as a huge organization in the United Kingdom, also recommends MDT working for the intrapartum care of women with pre-existing medical conditions. So Tayside has an obstetric MDT, and some of you would have already been involved with various patients. But the key message we want to send out, or I want to send out today, is that if you have concerns about a pregnant or recently pregnant woman, refer her via email or call the obstetric consultant on call. Dictated letters can actually take a long time to get to us. So if you are concerned about a woman, contact us. So what other conditions affect women of Black origin? So women from Black African, African, Caribbean, South Asian backgrounds are at risk of developing type 2 diabetes from the age of 25. And this is at a much younger age than their white counterparts who have a risk of developing diabetes after the age of 40. It's also important to know that diabetes in women of Black and Asian backgrounds will occur at a lower BMI than the obese category that we use for white counterparts. And this is the basis of why we screen Black women for gestational diabetes in pregnancy. Another condition which affects Black women disproportionately is sickle cell disease. Sickle cell disease has its origins in sub-Saharan Africa and the Middle East. So it's most prevalent in individuals of African descent, as well as the Caribbean, Middle East, and parts of India, Mediterranean, South and Central America. In the UK, it's estimated that we have between 12 to 15,000 affected individuals. So just as a reminder, what are the complications of sickle cell in pregnancy? It increases the incidence of perinatal mortality, preterm labor, fetal growth restriction, acute painful crises, spontaneous miscarriage, antenatal hospitalization. It increases maternal mortality, delivery by C-section, infection, thromboembolic events, antepartum hemorrhage, and some say there's also an increased risk of preeclampsia and pregnancy-induced hypertension. HIV has a very personal story for me personally because, as you know, I come from Zimbabwe, which is in the southern part of Africa. And I have to say that HIV took a huge toll in my country. So I'm very familiar with HIV and the consequences of AIDS. There are an estimated 30,000 women living with HIV in the UK, and this is a study from 2017, sorry. And HIV transmission is continuing in the UK. 57% of all women who were newly diagnosed acquired HIV in the UK. So it's contrary to what we sometimes believe, that women come with a certain disease into the UK, they actually acquire it here. Among women born abroad and diagnosed with HIV in 2017, 42% probably acquired HIV after arrival in the United Kingdom. In 2017, 1/3 of the 30,000 women diagnosed with HIV were aged 50 years or older, and 2/3 were of Black African origin. 21% were white. The number needed to test to diagnose one HIV positive woman is 137 amongst Black Africans, 1 in 3,000 amongst white women, and 1 in 1,000 amongst Black Caribbean women. Another condition which we need to talk about today is female genital mutilation. So what is FGM? Female genital mutilation involves the partial or total removal of external female genitalia or other injury to the female genital parts for non-medical reasons. The practice has absolutely no health benefits for girls and women, and it's estimated by the WHO that more than 200 million girls and women alive today have been cut in 30 countries in Africa, the Middle East, and Asia, where FGM is concentrated. FGM is carried out on young girls between infancy and the age of 15. FGM is a violation of the human rights of girls and women. This is a map showing the prevalence of FGM and the percentage of girls and women aged 15 to 49 who've undergone FGM by region and country. So you can see where it's concentrated within the world. It's important to know that whilst this is a map showing the origins, we still have women within the United Kingdom, girls within the United Kingdom, whose families have origins in these countries, who may be sent back to undergo female genital mutilation. We understand that there might even be pockets of society where they may continue to practice FGM within the United Kingdom itself. In the United Kingdom, FGM is illegal. We have the Female Genital Mutilation Act of 2003, and in Scotland, the Prohibition of Female Genital Mutilation from 2005. We also have the Serious Crime Act of 2015, and it is an offense for anyone to excise, infibulate, or mutilate any part of a woman's labia majora, minora, or clitoris. The important thing to also realize is that it's now also a criminal offense to carry out FGM abroad and to counsel or procure the carrying out of FGM abroad, including in countries where the practice is legal. It's also a crime to fail to protect a minor in the United Kingdom from undergoing FGM. Health professionals should ensure that in consultations with these women, that it is a safe and private consultation, that you would approach the conversation sensitively, non-judgmentally, and use professional interpreters where necessary. Do not use female members to act as family members to act as interpreters. All children with FGM or suspected FGM should be seen within child safeguarding services. Clinicians should be aware that psychological sequelae and impaired sexual function can occur with all types of FGM. This is a slide just showing you the types of FGM. They can be minor, but they can also be severe, where you literally have excised the clitoris and all the labia, and a woman has a pinhole or a very small opening for her to menstruate through and to have sexual intercourse. I've listed here the 4 types. I think there's an ongoing debate about type 4, which says it is, which includes harmful procedures to the female genitalia for non-medical purposes like pricking, piercing, incising, scraping, and cauterization of the genital area. So what are the complications of FGM and why is it important? Well, there are early complications, which include hemorrhage, urinary retention, genital swelling, fever, infections like tetanus, urinary problems, wound healing problems, injury to surrounding genital tissue, shock, and even death. Late complications of FGM include genital scarring, urinary tract complications, dyspareunia, aparunia, and impaired sexual function. We've talked about psychological sequelae and menstrual difficulties, genital infection and PID, infertility, HIV, hepatitis B, and in obstetrics, we worry about the complications of prolonged labor, postpartum hemorrhage, perineal trauma, and perinatal death. The RCOG has a guideline for FGM and its management. The next topic I want to talk about, which concerns Black lives, is mental health issues. So Black, Asian, and minority ethnic men and women are more likely to come into contact with mental health services. They're more likely to be diagnosed with a mental health illness. They're more likely to be detained under the Mental Health Act. In addition to a greater diagnostic prevalence, the additional negative effects include the further deterioration in their mental health due to discrimination. I'm going to talk about domestic abuse. We're in a pandemic, so it's important for us to be aware that domestic abuse still happens, and it is likely increasing with the pandemic and the lockdowns. So the definition of domestic abuse used by Police Scotland is any form of physical, verbal, sexual, psychological, or financial abuse which might amount to criminal conduct and which takes place within the context of a relationship. The relationship will be between partners, married, cohabiting, civil partnerships or otherwise, or ex-partners, and the abuse can be committed in the home or elsewhere, including online. Statistics from 2018 to 19 showed, unfortunately, that Dundee has the highest rate of domestic violence per 10,000 population. 4 out of 5 women, in 4 out of 5 cases, it is a female victim with a male accused. Domestic abuse is higher on Saturdays and Sundays than any day of the week. So this tells you that when men and women are in the same household, things go wrong. 88% of all domestic abuse incidents occurred in a home dwelling. In a 2000 report by the Scottish Executive, it stated that the prevalence of domestic abuse amongst Black and ethnic minority groups was unclear. Women from Black and ethnic minority groups may face particular difficulties in reporting domestic abuse as they are marginalized and isolated from the wider community. Many of them live with extended family and may find it difficult to raise or discuss the issue. Some communities that believe that problems should be kept within the family. There's a reluctance to approach providers, and there's a fear of racism. There are also issues related to spousal visas. There's a lack of financial security, lack of social support, and there are some cultural expectations and norms where domestic violence may be more tolerated in certain groups of society. The Scottish Government has published a lot of posters which we should be aware of that are particularly pertinent to the pandemic, to give women support and numbers to call if they feel that they are in danger. Okay, so we've been talking about quite heavy topics. I'm gonna talk about keloid scars, something a little bit lighter. But we know that Black women are more prone to keloids. So you should inquire about their personal history of keloids. We should look at scars and ear piercings and think about non-absorbable sutures. And this relates to obviously operative work where we are, or surgical work when we are operating on Black women. Some miscellaneous facts: some Black women may be less responsive to beta blockers, e.g. labetalol, when you're managing hypertension. Contrary to expectations where Black women are labeled as having difficult veins, and sometimes I know members of staff who will not even attempt to take blood or cannulate a Black woman because they feel they've got difficult veins. But the majority of Black women do not have difficult veins. We know that the lordosis that Black women may have may make spinals more challenging. We know that the lordosis may also cause late engagement of the presenting part in labor, so be aware of that. It's also quite, I think those who've known me over the 7 years where I've been at 9 Wells have seen me change my hairstyle quite frequently. This is a cultural norm. We change our hairstyles, and sometimes the hairstyles should be assessed because sometimes they may be quite voluminous and may make it difficult for an anesthetist to access the airway. I'm going to now talk about gynecological issues in Black women. We're going to go back in history first and talk about James Marion Sims. And there's been a lot of controversy about James Marion Sims. So you can see a picture of what we commonly use, and that's a Sims speculum. So was James Marion Sims a tyrant or a man of his time? James Marion Sims was an Alabama surgeon who carried out a series of experimental operations on Black slave women between 1845 and 1849. And research was conducted on enslaved Black women without anesthesia. He developed the first consistently successful operation for vaginal fistula, which is a complication of childbirth. There are a lot of papers which have looked at James Marion Sims, but I tend to agree that society has moved in a different direction. Some women were reported as willing because they were desperate to get a cure for this debilitating condition. It's difficult to make fair assessments of medical ethics of the past and be mindful that slavery was the norm in this time. His intentions, I believe, were to cure women of debilitating conditions, and his contributions to medicine are still very valid. Fibroids. Black women and fibroids. Black women have 3 times the risk of having fibroids. In fact, 25 to 80% of Black women have fibroids. It's important to know that fibroids occur at an earlier age. They usually are in greater numbers and they are bigger in size. Fibroids have a huge impact on the health, well-being, productivity of Black women, and they are an economic burden. A Black woman is 2.4 times more likely to undergo a hysterectomy than a white woman for fibroids. And they are 6 to 7 times more likely to undergo uterine-sparing myomectomy. I'm going to talk about breast cancer. The RCOG has published information which has made it apparent that Black women with breast cancer, for example, have a higher mortality rate than white women for several reasons, including stage distribution and tumor biology here within the United Kingdom. There is a condition called endometriosis, which is often ascribed to white women. and may be a disease of affluence. Traditionally, it's thought to affect white women more than Black women. It's unclear if there's a biological basis for the difference or whether it can be explained by social bias. This has resulted in delayed and missed diagnosis for women of other ethnic groups presenting with the disease. What this means is that we are underdiagnosing Black women and other ethnic minorities of endometriosis because of a lot of factors which I will speak about later in this presentation. When it comes to cervical cancer, there are still ethnic disparities in incidence and mortality, even with cervical cancer. The incidences of poor outcomes are also higher for those suffering with cervical cancer when it comes to Black women. The uptake of cervical screening amongst ethnic minorities in the UK are disproportionately affected by HPV-related disease, including cancer. We already know that the uptake of HPV vaccination has been lower in Black and Asian girls than in white girls. So likely this will result in an inequality in HPV attributable cancers incidence between ethnic minorities in the medium and long term. So what are the reasons for all these inequalities? I think the reasons are known to be complex and multidimensional. The disparities have been shown to clearly exist despite socioeconomic factors and other demographic variables. So we cannot attribute this to just socioeconomic factors because both low and high socioeconomic groups of Black women are affected. Bias. What is bias? It's a tendency to prefer one person or a thing to another and to favor that person or thing. What is implicit bias? Bias that results from the tendency to process information based on unconscious associations and feelings, even when these are contrary to one's conscious or declared beliefs. I'll leave that there for a minute because it might take a while to actually absorb this. So what is implicit racial bias? It is bias that is based on racial grounds. It affects the quality of care that Black, Asian, and minority ethnic women receive and can subsequently influence how women interact with health services. Implicit racial bias and discrimination remains a persistent problem that permeates every single aspect of healthcare in the United Kingdom, as well as in the United States. It also plays a part in poorer health outcomes experienced by people of Black, Asian, and other minority ethnic origins. It negatively influences the diagnosis and treatment options made by clinicians. It also negatively influences pain management. Indirectly, it affects medical interactions through the loss of patient-centeredness in treatment plans and the removal of patient autonomy. It feeds into a negative cycle where Black, Asian, and minority ethnic women and men avoid interactions with healthcare professionals. The stereotype threat is defined as a disruptive psychological state that people experience when they feel at risk for confirming a negative stereotype associated with their social identity, their race, their gender, their ethnicity, social class, sexual orientation, and so on. It's important to know that implicit racial bias is unconscious and often unintentional. We know it, as I've said before, it results in poorer health outcomes, hinders consultations, negatively influences the treatment options that we offer, and it leads to avoidance behavior. So what has the RCOG recommended? The RCOG released a statement on the racial disparities in women's healthcare this year, and they have said that Black, Asian, and minority ethnic women should be included in gynecological research. And we are recognizing now that there's a scarcity of data regarding diagnosis and outcomes in this group, and it's vital that medical research includes all women. And more research is required to better understand the impact of racial bias in women's healthcare and how it can be eradicated. The RCOG has also issued recommendations for training We need to establish a robust training program in medical schools to eradicate implicit racial bias and stereotypes. Bias and stereotypes are ingrained in the psyche from a young age. This is because of the society we live in. To combat this, a robust training program should be included in medical school curriculum to recognize the presence and impact of implicitly held biases on the patient outcomes, to embed positive behaviors. Training should include making medical students aware of explicit and implicit racial bias, how to facilitate and stimulate greater information and improve social change by, for example, creating a question prompt list for both clinical use and patient use. The GMC and medical schools councils must investigate if medical schools have such training and improve it where necessary. Where training does not already exist, the GMC and MSc must work with medical schools to develop an appropriate program without delay. The RCOG will consider its role, the role it can play in tackling racism and unconscious bias through its own training and education. To mark International Women's Day in 2020, the RCOG released a policy statement summarizing current information about the racial inequalities that persist in women's healthcare in the United Kingdom. The RCOG is calling for the government to tackle the issues related to racial disparities in women's healthcare. And they have recommended that action is needed swiftly with current trends showing an increased rate of adverse health experiences for Black, Asian, and minority ethnic women. These worrying patterns are not just visible in maternity healthcare, but also in infant outcomes. Breast and cervical cancer diagnosis and mental health support. We know that Black and Asian ethnic minority women are at an increased risk of having a preterm birth, a stillbirth. In fact, stillbirths at all gestational ages than white women. They're more likely to have a neonatal death and a low birth weight. The president of the RCOG, Dr. Edward Morrison, has come out with some statements saying that we are very concerned about the worrying statistics reflecting the racial inequalities in women's healthcare in the United Kingdom, and it is a priority to address this issue. There are no good reasons for the adverse outcomes, and we need to investigate and pinpoint the reasons for these disparities. So we know that the disparities health disparities for Black and Asian minority women show that they can receive a lower quality of care and experience poorer health outcomes, including high rates of morbidity and mortality than other women. We know that the disparities between the ethnicities are evident in all areas of healthcare. And the RCOG is committed to working with the UK government and stakeholders to eradicate health disparities in the United Kingdom. So the RCOG has launched an initiative. It has linked with an organization called 5 Times More. And there are 5 steps for healthcare there's a campaign called 5 Steps for Healthcare Professionals, where you should listen, remove any barriers to communication, check you're providing clear information, provide access to detailed documentation, and to be a champion. How can you be a champion? You support research and innovation in your hospital to help to end the disparity in maternity outcomes. You should inspire others by championing positive change in your maternity or obstetric unit. You can be a champion by valuing each and every woman in your care equally. This will help to improve outcomes for all pregnant women. You can look up 5 Times More. It was started in response to the publications from Embrace. So the RCOG has a race equality task force, which is to ensure that the RCOG is fully reflective on its stance on racial equality. It wants to address and understand how racism affects the fellows, the members, and trainees of the RCOG. It wants to improve awareness and training to combat racism within the health service. I think it's important to note that even amongst doctors and trainees, white trainees may be viewed more favorably than trainees of other ethnicities, and access to training is different. The RCOG, Race Equality Task Force, wants to improve undergraduate and postgraduate education in identifying and reducing racism and unconscious bias in the workforce. It wants to tackle the contributing factors which have led to poorer patient outcomes for Black, Asian, and minority ethnic women. And it wants to consider the role that medical research can play in addressing disparities in outcomes for Black, Asian, and minority ethnic women. We're going to go global now. I'm just going to have a sip of water. So I think it's been enlightening to see what happens to Black women in the United Kingdom. But globally, if you look at maternal deaths, in Western Europe, the risk of a woman dying is about 1 in 12,000, whereas in Western Central Africa and in Sub-Saharan Africa, the risk of a woman dying due to pregnancy is 1 in 28 to 1 in 38. That's a sobering slide. We know that cesarean section in low outcome countries causes a lot of deaths. So deaths from cesarean sections are 100 times higher in developing countries, and outcomes for women are far worse than expected. Data from 1990 to 2017 showed a quarter of all women who died while giving birth in low and middle income countries had undergone a cesarean section. We take cesarean sections for granted in this country. In fact, women now request cesarean sections for no reason. 8% of babies for women in low-income countries did not survive longer than a week after a cesarean section. The causes of deaths from these cesarean sections in low-income countries were a third were due to postpartum hemorrhage, 19% due to preeclampsia, 22% due to sepsis, 14% due to anesthesia-related causes. This underscores gaps in resources, skills to manage massive obstetric hemorrhage, and a need for specific training in this area. Right, we're going to travel from Dundee to Malawi, Lilongwe, and share some experience about how Dundee has been working to improve outcomes for women in third world countries. With the vision and the hard work of one of the anaesthetists called Katrina Connolly, obstetric and anaesthetic staff from 9 Wells have been involved in designing a self-sustaining, multidisciplinary obstetric emergency training course in Malawi called the MOTI course. And the last visit, as I understand, was in 2012 to 2015. This allowed hospitals to be involved. This showed that the hospitals involved showed a measurable drop in maternal mortality. The obstetricians and anaesthetists and the team that I know who were involved were Dr. Katrina Connolly, an anaesthetist, Dr. Pauline Lynch, an obstetrician, gynecologist, Dr. Wendy McMullen, obstetrician gynecologist, Dr. Katrine Orr, obstetrician gynecologist, and Dr. Rebecca Northridge, obstetrician gynecologist, and I think Lorna Murphy, one of the midwives. So the images show the generation of local instructors and supporting them to deliver the training course, because it's quite important for us to still reach out and support women globally if we can. This is a picture showing Dr. Katie Orr, who runs obstetric drills within 9 Wells, obviously doing what she does best. Here's another picture from the MOTI course showing again training for the staff. Here we have Dr. Rebecca Northridge, again involved in the MOTI course. And there again, we have the team training obstetric drills. More recently, Dr. Wendy McMullen has been involved in establishing a cervical cancer screening program in Malawi using acetic acid. This is on the basis of the aceto-white reaction, which detects abnormal cells on the cervix. So my closing statements are that one, racial bias exists, and racial bias is everywhere. We may not see it. It's in the shops, it's in restaurants, it's in the police force, it's in schools, and it is within the NHS. We have a duty to learn, to tackle it, and to train future doctors. The lives of Black women and babies matter, and the RCOG recognizes the inequalities that are present in the UK for Black women and other non-white ethnicities. We can all play our part and do more. And Black women should continue to educate themselves and not let the stereotype threat prevent them from accessing care. And I will end with this slide just as a reminder of the issues that face Black women in pregnancy. And I'll thank you for listening and hopefully taking some inspiration to do your bit in helping Black lives and Black women survive. Thank you.
Thank you very much,